do a little refresh, a little reset, and look back at the collaborative care team model. You can see the patient, it's at the center, the primary care provider, behavioral health care manager, psychiatric consultants are all there in the registry. This is from the AIMS Center. And if you haven't been on the website lately, they have so much valuable resource on there. I'm going to be referring to it a couple of times. And I wanted to actually have us watch a video that is just a couple minutes long. And I'm going to go ahead and show that now.
Millions of Americans struggle with mental health and substance use issues each year. But quality treatment can be difficult and expensive to access, often leading to a lot of unnecessary medical expenses if left unaddressed. We know that when accessible and done right, psychiatric treatment works. Many patients with mental health and substance use concerns talk to their primary care providers, or PCP, first. PCPs traditionally have had two choices: treat the issue themselves or try to refer the patient to a mental health provider, like a psychiatrist. Unfortunately, medical providers sometimes don't know how to respond or how to help patients access quality mental health care. In part, that's because there simply aren't enough mental health providers to meet the need of all the referrals. Wouldn't it be great if there was a way to get people seen that was timely, effective, affordable, less stigmatizing for patients, less costly for healthcare systems, and ensured access to psychiatrists who play a central role in providing effective, quality treatment? There is. The collaborative care model is a way to provide psychiatric services in the primary care setting. The collaborative care model has a rich body of scientific evidence supporting its efficacy. How does it work? The cornerstone of the model is a behavioral health care manager, a mental health professional who practices right in the clinic with the primary care team, ensuring accessibility. This care manager works directly with a consulting psychiatrist who provides the expertise to keep treatment on track and who is available to offer support on cases that need extra help. The model uses procedures for assessment and treatment that have been proven to work. It's an organized approach that ensures patients receive the most effective care and no one falls through the cracks. Treatment can include focused talking therapies and medication when indicated that's prescribed by the PCP and overseen by the consulting psychiatrist. This model makes quality mental health care more accessible to more individuals across the country. Seem too good to be true? Collaborative care is happening right now all over the country, and it's reimbursable by insurance. Psychiatric treatment works, and the collaborative care model helps more people access it. With this model, providers can focus on what they do best: help people get better. Interested in learning more? Visit psychiatry.org/collaborate for more information.
Okay, so there's the refresher. Let me stop. Does it look familiar to many of you? I'm sure it is.
3500.
Pardon? Oh, okay. Let me see if I can find my place again. So one of the things I wanted to do, reasons I wanted to share that was because I recently went to, in June, the Integrated Care Conference put on by University of Washington. And one of the things that the first speakers that spoke, the keynote speaker, Verna Little, she said she recommended we move away from models. And so the collaborative care model has been in place around 20 years, as far as I know, maybe even longer than that. So when we think of move away from models, I'm just like, really? Did she say that? Yes, she did. And there were some other speakers at the conference that talked about some things that made sense of why she said that. So we're going to talk today about some clinics that are integrating care for patients with dementia into primary care and alcohol use disorder into primary care. And also at the conference, there were several clinics represented there that were pediatric clinics. And they talked about using collaborative care in their settings. They were finding that their pediatricians were becoming overwhelmed with their patients with ADHD, anxiety, and depression. And by implementing the collaborative care model, it helped them provide better care and take some of that pressure off of the pediatricians. So I just love that. I found it so interesting to hear from these people, and we'll get into that a little bit more. But the second thing that Verna said that I thought was also helpful, and I don't know if all of you did this when you started your collaborative care models or integrating your behavioral health care into your primary care setting, but it's kind of like starting with the end in mind. So what does it take? What would it take to be able to have a sustainable program? Where do we need to be at month 1 after implementation, month 2, and month 3? This oversimplifies what you all know to be a very, very complicated financial picture. But really, you know, the pro forma, it's a method of calculating financial results using projections and presumptions. It's not meant to be 100% accurate because you can't be prospectively, but it's meant to give you a good picture of what would it take. And the experience of Verna, who helps a lot of clinics with implementing collaborative care, she said that the ones that did this really had a much more sustainable program, reached that point of sustainability more rapidly than clinics who didn't. So I thought that was valuable. And even best guess, you know, I think will help with this, depending on how accurate you would be able to be. And then the other thing to think about that she mentioned is starting out, is you know, she said it would be good to ask a question of what would it look like if we did a great job. So for instance, in the pediatric setting, caring for kids with ADHD, or caring for patients with dementia, or caring for patients with alcohol use disorder. You know, I think, you know, as we've gone through years of collaborative care, years of challenges with staffing, getting the staff with the licensure that's most helpful. Sometimes you just make the best of what you've got. But I think that's also true for your the patients that you're serving. Like, are you seeing a percentage of patients that are, you know, diagnosed with dementia, or, you know, are you seeing patients that need care with alcohol use disorder? So looking at all of those things and thinking about, okay, so, you know, what would it take for us to be, you know, sustainable financially, and what is the patient population that we serve, and how can we best align our resources to do that, to make the best impact as possible. Let's see. So looking at the AIMS website, there was some really helpful resources for billing. There's even, I don't know if any of you have attended before, but there's a monthly office hours set up that you can listen into, or ask to go there and ask questions about billing. And this is including RHCs and FQHCs. So I thought that was great because there are so many variances in the billing for those types of clinics. And I just hope that you're aware of it, and would like to share the link and things here in a couple of slides for you to have. I will also send out the links, the whole slide deck after the meeting today, and then that'll be available on the Greater Health website, Greater Health Now website. But I wanted to kind of pause there and just give people a chance to weigh in on those thoughts. Anything surprising to you, or, you know, you have anything to add about your experience with attending the billing, if you have the billing question session with the AIMS Center? Okay, hearing none, I'm going to move ahead and show you this resource I found. It's from the Medicare Learning Network. So you see the MLN booklet up in the corner. It's from May 2023. And as I look through it, I really appreciated the specific codes and specific information that are related to collaborative care and the billing. And again, I've given you the link for this resource in the next slide, I think, just so that you can look at it. But I just put the table of contents so you could get an idea of the different topics that are included here. You know, I know that sorting through what you're able to capture as far as revenue when it comes to billing for behavioral health integration, it can be really hard, really super challenging, hard to understand where you're really at. And some of these things might help. And so that's why I'm providing that for you here. So have people seen this resource? Are you aware of it? Just a quick yes or no?
Yes. Yes.
Good. Okay. Anybody else besides Kim?
I haven't. Where do we find it?
Roseanne, I'll just give you the link is here. So when you have slide deck, you can click on it. But it's at CMS's website. But I found it from being in that top link there about from the AIM Center, that first website. Frequently asked questions for billing collaborative care, very useful. And within embedded into that are several links, and the resources were helpful and good. So I know I often wish that I had those kinds of resources. So I just want to share them with you guys who are in the midst of providing this care and trying to capture revenue for it. Okay, we'll go ahead and move on. So one of the speakers at the conference was Dr. Heyman with Swedish Family Residency Program, and she talked about dementia and cognitive impairment in primary care. So she started off with talking about patients with dementia having 2 to 3 times greater total healthcare costs than patients without, and that 50% of the people with dementia actually go undiagnosed. It's a difficult diagnosis to make. And so she said, you know, if you think about also, you know, if someone has dementia, how difficult it is to manage the diabetes or CHF or other chronic health conditions. And so it's easy to see how that would result in an increase in unplanned hospitalizations and emergency department visits. So what they found in their clinic was that patients with dementia were hitting their integrated behavioral health specialist, and they were seeing it more and more. And so that they decided to really focus in on that and bring the collaborative care model forward to be applied to patients with dementia. When you think about what we've been doing for screening with for anxiety and depression with the PHQ-9 and the GAD-7, there are some screening tools here that she mentioned. And I know that those are in use in your clinics. And the side that isn't so particularly helpful for demonstrating an improvement in outcomes is that with dementia, it's not able to, you're not going to be able to typically show any kind of improvement. But management of the condition as it progresses is definitely part of what we could be doing and tracking. One of the things that was said about dementia by Dr. Heyman was that there's no cure. There are medications to help for a little while for some people. But the dementia patients, they need to connect with community groups, and caregivers need support. So it was really refreshing to hear how they incorporate the collaborative care model. So the first meeting when a patient receives the diagnosis, the family and the patient are meeting with the physician as well as the integrated behavioral health specialist to start helping the family understand what they're doing that may or may not be helpful, and helping them get some resources right in the onset of when they receive the diagnosis. So also mentioned was that we do have a resource in Washington State. It's the Dementia Roadmap, a guide for family and care partners. And I did take a look at that roadmap, and it really does have a lot of good information and very helpful. Just as an aside, to get to learn about that was really, really good. So interesting to see this and think about how this might be helpful for you in your clinics. Also, another presenter I found really helpful and kind of applicable to our work was Dr. Christensen. She's the Chief Medical Officer for the Indian Health Service, and she spoke about community-based workforce in the Indian Health Service. So I was so surprised to hear about some of the parallels that of the work that has already been done in the Indian Health Service, how it's similar. I mean, one of the main things that they are doing in the Indian Health Service is using these connectors. They have a community health aid program, and they have community health aides, dental health aides, and behavioral health aides. And they've worked out training programs for them. And within the training programs, there are different levels. So people that are culturally attuned to the patients that are served in the Indian Health Service it's so helpful that they're getting information or help from people that understand the culture and the constraints that the people are under. And I included a link here for the Tribal Community Health Partner Program, so you can go and look and see how those things are being addressed with the it's really the health related social needs, and how that's just this homegrown program that has equipped people within their culture to provide services that are so very needed. And even with that, those people that are functioning in the roles as aides are getting paid, and they're also part of getting education and getting competency testing and being certified in their positions. So it's helping overall kind of elevate them to be able to continue to help in a broader scope within their population. So I didn't know if has anyone on the call heard of these community health aid program, or the aids, or overall anything about this in the Indian Health Service or the population?
I have heard wonderful things about it. I am not too educated in it, but I've been to a couple conferences where they've talked about using those mostly in the New Mexico area, where I've heard, and I know they're starting to use them in the Yakima region, but I've heard great and wonderful things about it.
Thanks, Brian. Yeah, when I got into the website, I was looking, and the Heritage, I think, University is offering training for people in the health aid positions, and certification as a behavioral health aid, I believe it is. So it's so exciting. I love this work, and I do think that there's a lot for us to learn. I think sometimes we have a question about, okay, well, how can we use a community health worker? And they're pretty far down the road on how to use community health workers, although the community health aid program do not refer to the community health aides or dental health aides or behavioral health aides as community health workers. But I think we who are just getting the hang of using community health workers can learn so much about the specific duties and things that are happening within this context, and the positive outcomes that they're seeing. So I just wanted to make sure I referred to this work and have it on your radar that you might get some ideas for you using community health workers, those of you who have them or are thinking about adding that to your staffing mix. Okay, and so another speaker I wanted to highlight of a new application of collaborative care was treatment of alcohol use disorders and integrated care. So Mark Duncan, he's an addiction psychiatrist and former, I think he was a family practice. He was in primary care practicing. He spoke, and it was just wonderful to hear what's happening in the clinics that he works with. So he began with some statistics. About 94% of people with alcohol use disorder don't get treatment. And as we know, it's a part of the disease that they don't think they need it. So particularly difficult to engage into treatment. And then a quarter of the people with AUD have depression, and over the lifetime that increases to 40%. I would say at least for people with this disease. It's so difficult. So he talked a bit about, okay, so why would we invest in this or really try to have AUD as a focus for collaborative care? And it's increasing access to this care. So many go untreated and don't turn to things that may help, but will go to their primary care providers and have an established relationship. So we'll perhaps be a little more vulnerable in sharing about their disease. Decreases the stigma. Receiving care in the primary care setting is less stigmatizing than going to a treatment program, and it might be, like we just talked, you might be able to engage treatment in this way. And he even talked about, a little bit over time, and then eventually he's seen some people that even though they didn't really want to engage in the way that the team would have liked to have the person engage in treatment, that just a little bit helped. And then over time, sometimes they do see people that fully engage and experience increased health and sobriety. So obviously the decrease in incidence of SUD and improve physical and mental health, and then decrease costs of healthcare. So again, there are screening tools. The Audit C is one that's in use, and then the SASQ is the single alcohol screening question. How many times in the past week have you had 4 drinks or more in a day for women, or 5 for men? Just that simple question can get a conversation going, and maybe just a little conversation initially, but moving on in your relationship as a provider with this individual may lead to more conversation in that trusted relationship. So it was really exciting. I know there was another attendee in the session I was in who had really worked to integrate alcohol use disorder, helping people with alcohol use disorder into primary care. The team, wouldn't it be lovely if we had an addiction psychiatrist just readily available? I think that, if we could use one in each, of our communities and be able to access that specialty as we do for a psychiatrist in collaborative care, it would be fantastic. So I think it's wonderful that it is happening in the clinics over on the west side with the University of Washington. But that's what they get to do. They get to have their primary care providers have someone to talk to, have some for suggestions, for understanding medications that are available. And Dr. Duncan went into those medications a bit and talked about how to prescribe. And there's just so many nuances that's unknown. It would be a wonderful resource to help people with AUD have access to this type of care. And then there is, Dr. Duncan is a co-medical director for the University of Washington Psychiatry and Addiction Case Conference. Its acronym is UWPACC. It's a weekly educational webinar and consultation service for Washington State. I know at least one person on the call has heard of it, and I'm not sure if have accessed the resource, but it's Thursdays from 12 to 1:30. I have the link here. You can go onto the website and download a flyer for your providers. So if you're in your practices there's patients that they are kind of stuck on, or maybe they want to find out more about the medications that are available for treatment with of AUD. This is a resource and available for free. So I just wanted to, again, give you guys some tools and things that might help you better serve your patients. So I'd like to kind of pause there and see if anyone would be willing to share or mention if they have used this resource. Has it been helpful or not? Have people been aware of it?
I'm not aware of it, Laurel.
No? Okay. I don't know, Dr. Taylor, are you still on the call?
Yes.
So
Yes, I'm still on.
have you been able to access this resource?
I have not. It looks like a great resource, though. Looks really good.
Okay, all right. Well, great. So hopefully, you know, when you guys get the slide deck, there's some of these links will be good for you to look at and use to serve your patients. But I think it's so interesting to think about, you know, these changes that we've seen with collaborative care come, you know, after so many years of really just kind of focusing in on anxiety and depression. And it makes sense, you know, when you have these people in place in your clinics that some of these things outside of anxiety and depression are going to come as referrals for your collaborative care program. But what I wanted to do is to go ahead and move on to have us do some sharing and go around for the people that are in our room today. And what I'd like you to do is just share at your clinic what's going on for integrative behavioral health. And then in another slide coming up, we'll have a chance to share about your challenges that are happening with trying to have this program in place. So with that, we'll go ahead and start sharing. And so I guess we'll start with, is this you, Dr. Taylor, XAV?
That's me. Yep. Yep.
Okay. So I'll start at the top with you.
Okay. Well, Laurel, I know you know our integrated care very well. We have modeled our system after the collaborative care AIMS project from the University of Washington. And we have a behavioral specialist. In fact, we just got a new one who's replacing someone that left last fall. But we have done integrated care since about 2018. And the model is pretty standard. We screen all of our adult and adolescent patients with a PHQ-9 every visit they come in. And the idea is if someone screens positive, and we chose a score of 10 to be our cutoff, someone is above the level of 10, the PCP is alerted whether they're for high blood pressure or diabetic follow-up or sprained ankle. The PCP is alerted, and the PCP discusses with the patient, and if it seems to be actual depression, not just their dog just died or something, then they are handed off as much as possible with a warm handoff to our behavioral specialist who is co-located with our primary care clinic. The behavioral specialist then does an intake, and if they don't have time at that moment, they at least try to introduce themselves to the client, might see them later that day, or if necessary, schedule them in the next day or two. But they do an intake. They might do other screening tools like a GAD-7 or other tools, reach an appropriate diagnosis, whether it's just depression or SUD or other things. Then they engage short-term behavioral therapies. And short term, we try and keep it to no more than 6 months. If someone has significant psychiatric problems or more significant psychiatric diagnoses that would require much longer therapies, they are referred to our behavioral health center, Lourdes Behavioral Health, where they engage in more formal, ongoing psychiatry and behavioral health therapies. So assuming that a patient, and our goal is to catch undiagnosed early to mild depression or early to mild anxiety disorder before it becomes severe. Understanding that patients that are treated early are less likely to progress to more severe stages and do better with their other medical problems as well. So patients are taken in, they're entered in our registry, which again is an AIMS registry, modeled after the University of Washington. Once a week, our therapist panels in the new clients or clients that aren't getting better with their psychiatrist. And our psychiatrist then interacts with the therapist. They both the therapist and psychiatrist have access to the electronic medical records, so they can see other medicines the patient is on, other medical problems, other diagnoses. The psychiatrist makes recommendations to the therapist about certain therapies, might make recommendations to the PCP about certain medicines. And so it really is a tripartite model where the therapist, the PCP, and the psychiatrist have input into this patient's health. As time goes by, if we see through the registry with serial PHQ-9s or serial G87s that the patient is not progressing well, then special interest, special efforts are put into that client. If they're progressing, then they're given they start a plan for exiting and a plan for maintenance, and it goes on like that. We found that has worked really well. A lot of patients are really very helped a lot. Even a lot of clients that initially said, "No, I don't really want to meet a therapist. I think I'm doing okay, doc. Thanks anyway," who agreed to meet once. Found that that one visit was extremely helpful, and then they wanted to engage and carry on, and ended up being even some of the people that seemed most resistant at first ended up really opening up to the therapist and really engaging with some very meaningful therapies. And those people did do better with their lives. They did do better with their other medical problems in general. And so we felt that was extremely effective and useful. There are always some patients that don't want to do a PHQ-9, refuse to do so. We've had a little bit of trouble in our, and I won't get into, I know you're going to get into challenges, but we've had some therapists come and go, so we had a little trouble keeping a therapist. But when it's been engaged and working, it's worked really well. Our PCPs love having a therapist right there whom they can talk to, they can engage with. If they have a patient with an acute psychiatric need that isn't just depression or anxiety disorder, they can consult with this therapist who often can advise them how to approach a patient and so on. And that's basically it. It's all time-based. We convert the times that are spent with the client into time-based codes, which are official collaborative care codes that have allowed us to bill then for collaborative care services. And it's actually reimbursed pretty well, believe it or not. Yeah, through collaborative care codes. So that's probably most of what I have to say, Laurel.
Thanks, Dr. Taylor. And that's a lot of work. I mean, there's so much, and it makes sense that you've been at it since 2018, because I know everyone on the call can attest to how challenging it is. So congratulations on all the progress so far. Good job.
It's definitely been a team. Definitely been a team effort. Thank you.
Okay. And so Jade, I'm going to call on you next. I know that's a tough act to follow, but if you can, and Jade is kind of, and Marcia, I don't know if Marcia is still on or not, but if you guys want to explain what's going on with your clinic.
Yeah, you're killing me. You're so we are very, very new to this. And this is not my expertise, it's more so Marcia's, so bear with me. But so we have just started this. So we screen all of our patients, we have just started screening them at least yearly with the GAD7 and the PHQ9. And then new patients are screened on their initial visit also. And then follow-up screenings are done at least yearly or more often if they were found to be a positive screening. And then they're referred to our behavioral health provider or LSW for positive screenings, which those programs we do via telehealth, but it's via our clinic. And then they're followed via our telehealth program, and then our PCP, the patient's PCP, and then the telehealth program work very closely together, and they work from our same EHR system. So that makes it really nice so that everybody can see everything together. That from there, the screenings are kept up, the self-management support, the care plans are all within the system, and the patient is then followed at least monthly or more often if needed.
That's-
Yeah.
That's awesome. I think you did fantastic, Jade. And I see Marsha's on the call. So Marsha, do you have anything to add? Maybe she's like in the clinic working, but
She is in the
logged
clinic
in.
working, going back and forth between patients and stuff. So,
And you guys are Pomeroy Medical Clinic.
yeah.
So I didn't know if everyone knew that. So, okay. Thank you so much, Jade. I really appreciate you going out on the limb. And as far as I understand it from calls with Marsha, that's exactly the way it is right now.
Yep. I did like that the gentleman before me that they were doing the screenings with every visit. I think that's really good to do. So that's something that I'd like to take back to our team.
Perfect. Okay. Okay, so we will go ahead and move along to Kim. And if Shane wants to chime in as well, that's fine.
That's what I was going to say. Shane, do you want to chime in first and then I can add?
No, go ahead, Kim.
Okay. So I'm going to start by going way back a million years, because back in like 2010, I worked for University of Washington in one of the neighborhood clinics, and we started this pilot program that grew and grew into this. So I have some back experience with this. But anyway, and I can't remember the dates, but we started with the University of Washington doing the AIMS program, just like people have described here. And then probably when we get to hiccups, when you have your program based on the people who are here and the people leave and you're kind of left and you go, how do I fill this gap? And you're in a rural health clinic, it can be some starts and stops and put something on hold and start again. So currently we have LICSW, we have somebody else in the works. We have a telepsychiatrist, so we can do the co-CM. And so we are running the program much like everyone else. We have everybody on a registry or a list, however you want to say that. We do our PHQ9 and GAD7s once a year for sure, but for people who have history of depression or who are seeing a behavioral health specialist, they do that every time, and all of that is recorded. We all use the same medical record. The LICSW talks with the psychiatrist, and what he says staffs patients, and so just like the first speaker discussed, then they send notes to the PCP and to the LICSW. So we're all on the same page. Everybody knows what's suggested. The patient knows that they're at the center. They get calls like, you know, we've talked about your case and, you know, come in, we want to talk more about it and get you on the right path. And what we have found is that you're, for lack of a better way to say it, you're like garden variety depression and anxiety are not the mainstay. We have a lot more complicated as people. We're a lot more complicated than that. And so the short-term things don't always pan out to be short-term, and they become more longer term. And so we work on getting resources for that.
Very well said, and such good work. When I hear these stories, I just think what amazing work you're doing, because I know the resources are quite limited, and yet you are persevering and going forward with this model. And because it's a way to help people, it's in the bottom line, it's about the patients, right?
Kim, did we change the SUD screening, or which tool are we using for SUD?
So we're getting a new tool for like the drug part of SUD, but for like alcohol, we do use the audit C, and it goes to the audit if it's positive.
Okay,
The
and
last-
did you
sorry.
guys, I'm sorry, I don't think that we said your name of your clinic.
Oh,
It's
for us?
It's
Oh,
Columbia,
yes.
Columbia Family Clinic and Waitsburg Clinic, and then we do have a College Place Clinic as well.
Thank you. So pretty amazing, all that work that you're doing in your rural location. I really appreciate your sharing. Okay, so let's go on, and then Roxanne, can we go ahead and have you share next?
Sure, I was typing, so it's gotta go, but I was like, I had to leave early. So we have 2 integrated behavioral health consultants. That's what we call them, but they're licensed social workers within the family medicine department. There's like 14 providers in the building. They are going to actually split out now into our other clinic across the way. This is in Walla Walla, and they're integrated with the primary care teams. They have the warm handoffs, so the quick visit with the provider, but every patient that comes into our PCP appointments fills out the PHQ-9 based on the scoring, goes to the GAD-7, so it's just on the back of the piece of paper. They just fill it out, and Epic for every wellness visit automatically, and that's our EMR sends those questions to the patient. So that definitely eases our way. And then basically it's pretty much on a referral basis from the PCP. Many of our PCPs have been managing a lot of this on their own. And so some like to do it on their own and some refer out to behavioral health, but definitely on the counseling pieces for the social worker, they're definitely being utilized routinely. They do short-term kind of visit, just like the gentleman at the beginning. I think it's like 10 visits, but there's been many patients that wasn't enough and there wasn't anywhere to send them to. And so they tend to keep them a little longer, but they follow up with the PCP, and we kind of all agree that's the right thing to do for the patient. But like he said too, many of them, and it's just a couple visits, and they're so grateful for the support that they got in our clinic that they're all better. And then, and then they know that that's a resource that they could do if they needed. We also have and that has been within like the last year. And I loved how you do the performance. This is the goal. We didn't do any of that. And so right now, and we don't have panel lists, and I'm listening going, those would be really good. I have a feeling there's I think we're starting to silo ourselves in the work because they're getting so busy that they're not collaborating maybe enough with the PCP on the care of the patient. And yes, there's HIPAA and there's confidentiality things based on those visits, but how do they collaborate with the PCP a little better, I think. And then we have added a nurse practitioner. She is not certified in psychiatry, which we've learned that causes a billing issue for some payers, but she has that experience. So she's doing more medical management, and I think she started Suboxone, and I think this is a lot. I'm trying to assist, but it's so much for me that I'm trying to learn it all. But and she is only seeing our patients, the PCP patients in our medical group currently. And she is pretty full and trying to talk about how many new patients can she really be doing. And this is the kind of where I'm feeling pretty full and what we're doing, but
yeah, it's a good problem, Rustan, and yet it's like, well, where do we go from here? You know, I think the sad thing is when you get people in place in the program and, you know, figure out documentation and billing, and then you're underutilized. I think that's a really, really tough problem. I think I would rather hear about that you're getting well utilized and how do we go from there? So,
Yeah, most definitely. I mean, they're full, they're not sitting around going, what do we do next? And there was a period even with our counselors where cause I give them warm handoff time, like half a day, and they rotate. And then they're seeing patients, so, you know, they're on patients. And we built it's probably off of the AIM statement, but, you know, from that team, but from the University of Washington, but we built ours off of Spokane. So that's how we built it, and so that's how they were doing it. And we did learn that it was beneficial for our social workers with our integrated team to go to the huddles with the PCPs. And then they talked about what patients were coming and maybe this will be a good patient. And then sometimes even our counselor will go in and introduce themselves even before the PCP even has a chance. So integrating, we gave them a brochure that talks about the billing pieces, that if you do use our services, but kind of being more like they're part of the team, not just such a silent. So we found that really helped to fill up the schedules.
such good work. Thank you so much for sharing, Roseanne. I'm gonna go ahead and go to Michelle and Mike, and if you guys want to present from your clinic.
Mike, do you want to talk or do you want me to talk?
I think you're in a much better position to explain
All
this.
right. All right. So behavioral integration for us, we have a psychiatric nurse practitioner. We have several clinical social workers. We have community health worker, behavioral health extenders, and we have substance use disorder professionals. Our goal, as is the goal of many here in the pilot, is to screen everybody at least once a year for depression. We also use the GAD-7, as many of you do. Our behavioral health providers are there for those warm handoffs with our medical providers whenever someone screens positive on the PHQ-9 or for a variety of other, conditions, any sort of anxiety, suicidality. Our behavioral health providers also participate in our MOUD program. We do focus on those brief intervention strategies. We primarily use CBT. And then if there is a patient that needs a higher level of care or a longer duration, we do try to assist them in bridging care with us while working on getting them through that sort of intake process, finding them appropriate services for that longer term. That's one of the benefits of the behavioral health extenders, is that they can kind of help support during that process, navigate, some of those sorts of things.
Michelle, what is the licensure of your behavioral health extenders?
They are community health workers. So not currently licensed. They might be, someone going to school working towards that. But not currently licensed.
It's interesting. It brings to mind, the Indian health model that I was mentioning, with someone culturally competent to talk with the patients. I think that's integral and so important. So
yeah,
thank you.
And that's the newest part of our group, are those behavioral health extenders. So
very interesting. Okay. Did you have anything else to explain or?
I don't think so.
Okay, awesome. Okay, Stacy, you're up.
Hi, good afternoon. My name is Stacy George from Community Health of Central Washington. And we have pretty big integrated behavioral health program. We actually follow the PCBH model for primary care behavioral health and have integrated behavioral health providers at all of our clinic sites. So we have a total of 23 behavioral health providers, which I was shocked to learn yesterday. I knew we had a lot, but not that many. We keep their schedules all scheduled at 50% capacity, allowing for 50% of the patients, 50% warm handoffs, basically. And we do, like a lot of people in this call, we screen all of our patients at every visit for depression using the PHQ-2 and 9. But we also, our BHCs also work really closely for chronic disease management. So if you have a newly diagnosed diabetic patient who really needs to set goals and some lifestyle changes, they will often meet with our BHC team to do create some care plans and set goals and, identify barriers. We have one psych ARMP on staff who works with our BHC team and our providers to recommend medications and manage those medications for our high-risk patients. We also have a decently sized transgender population that we all automatically connect with our behavioral health counselors, as well as a substance use program that have one BHC dedicated to their staff. We also have learners, which I think is really cool. We have a residency program, and about 5 years ago, we started bringing in behavioral health learners. So we have interns come and study under our more seasoned BHC providers. And that really does help us, be able to see more patients. And then a lot of them stick around too. So it's been really great to see that growth and see those people come in. But I will say, we've had this in place I've been at CHCW since 2012, and we've had behavioral health counselors then. However, it was one person on site. It started really growing in about 2015. We kind of started really growing our BHC program and are to where we are now with that volume. So it's a really great program. Our patients have really great success in managing their chronic conditions and their behavior and mental health. And it's a great resource for our teens too, that definitely utilize our BHCs.
Thank you, all of you. I thank you so much for sharing, and that was so rich and so much going on. And, over the years it wasn't that many years ago that we didn't have anything in place like this. And so what a huge improvement we're seeing in the healthcare that we're able to provide for our patients, and especially assisting with depression, anxiety. I'm going to skip the video, and then if we can, actually, I'm going to skip that and go to major barriers. And after major barriers, I'm just going to give this both to you in the interest of time. My last question was, what is one thing you would ask IDO, the integrated healthcare genie, to advance your current situation? And so I know that Greater Health Now is really wanting to come alongside and help in ways that they're able to. And so that's why that question's in here. So we have just 5 minutes. So what I'll do is just have you, I'll do a whiteboard for this, but I'm just have you, it kind of goes along together, just state what the barrier is that you'd like help with. So we'll just have to narrow it down that way. So let me see if I can get, and I think probably you guys are familiar with the whiteboard that you can just, I think you put more actions with that top little thing, and then you just click on the T to be able to text in, and then you can put your answers in here. So we'll go ahead and have you guys start doing that, and we'll finish up here and wrap it up, and we'll give you 3 minutes. That's not much, but hopefully you have some good wishes on your mind. Better health integration in the EHR, yes.
Wonder if there'd be more wishes on there. Like you put a genie on there and everything. I was expecting it to like
Their wishes, I think, are probably complex and they know like some things. are
right. I'm
like,
like
give me more
snacks.
yeah.
I'm technology challenged. I can't figure out how to put it in there, so I put it on my chat, in the chat.
Oh, are you okay, Roxanne? So I think, one of the things, as the person that meets with you for this accountability, this tracking of outcomes over time to demonstrate, that there's a plan or how the patient is responding to the interventions is pretty difficult. And I see that as a need, but I could be off base on that. I don't know. What we can do, since we're out of time, is if you guys, I will ask you at our meetings coming up to let me know what your thoughts are on this. And or you can email me like right now at the end of the meeting, and let me know what your thoughts are, so that we can see if there's anything we can do to align resources for you, or I don't know, it's one of our future, have someone come to present something at one of our future shared learning webinars. But these things I see here, an integrated system of tracking patients and condition severity, I can see how important that is. The integration of behavioral health into the EHR, so tricky because the EHR seem to really be made, planned, and for physical health and not that integration. A robust behavioral health workforce, that would be the one for the genie right there. And then CMS recognition of additional behavioral health certifications, license levels in rural health clinics, right? That's probably Shane or Kim, I'm guessing. You guys want to expand on that at all?
Well, right now we can bill for LICSW and LMHC, and I think maybe marriage counseling. And 2 are new. So before it was only LICSW and no one else. And so then what do you do? Because sometimes you need to offer the services, and you have like somebody with masters in social work who can do the counseling, but then you can't charge. And so how sustainable is that program?
Right. Yes.
So they're inching a little, like this year we got the LMHC, so that's good. But it's still difficult, and we're still going to do some tele like they're doing in Pomeroy, because sometimes these people don't want to move to a town of 2,500. I don't understand it, but that's how it is sometimes.
I don't know, Kim. Yeah. Okay. Thank you so much. Thank you for your sharing, and I really appreciate your attentiveness to our topic today. And we'll look forward to our next shared learning webinar on September 26th at 1 p.m. So thanks so much, and goodbye.